Welcome to Ask Dr. Andy. Different theme songs for Andy. Welcome. All the comments and statements by Andy are purely for entertainment purposes. Hello, Andy. How are you today, buddy?
Hey, it's great to be here again.
Now, we have a brand new sponsor we're talking about today, and that's our at ericjavits.com. That's ERICJAVITS.com. Chic, protective, iconic. Eric Javits. Javits is the essence of against setting trends with like travel-friendly sun hats and sophisticated accessories. And when you go to Eric, for our northern friends, their shopping cart, and for our Texas friends, y'all put that stuff in your buggies. You can put in the promo code Buffalo for 20% off. Once again, that's ericjavits.com, and check them out. They got some pretty bougie. Was that bad if I said it was bougie?
No, I don't think so.
I don't think so. But welcome everybody to another fine episode of Dr. Andy. I think I move over a little bit, Andy. We were messing around with the camera before the show. Wait a minute, you guys didn't see me. You've seen me all the time. And we're screwing around a little bit. Andy, this is your dozen. This is bacon dozen. Yes. I can't believe. Can you believe it went by that fast?
No, I can't. I look forward to today where we get to talk about just pick things you're medically afraid of, and we can unpack them and kind of the real from the not real, kind of give people a bit of peace of mind with some and rational approach with others.
Well, I'm kind of glad you picked the subject that we are going to talk about today, because unfortunately, cancer hits everybody that we know.
Yes.
Whether it's a friend, a family, whether it's you yourself, maybe it's a little scare that you don't even, you might not have cancer, but you still got to go through all the rigmarole of checking everything. You look so different there. You're so handsome. I liked your hair there.
I was going to say, if I could carry that icon with me the rest of my life, I'd be doing pretty well.
Look at the guy over his shoulder. He's very sad. Is the blue ribbon, is that for cancer? I don't even know.
I'm not real sure.
Not one.
I try to keep my patient from that.
Not one of my better logos. So you can't hit the ring, get a home run all the time, unfortunately.
As the person who had a cancer scare, I agree with the topic. So fire away. Here's the most.
Okay, well, you didn't tell me you had a cancer scare, so I want to know what type of cancer was it?
Oh, we were looking at prostate.
That's scary.
Fortunately, I dodged the bullet, and my prostate is happily in a specimen container someplace in North Carolina.
So why didn't you just masturbate more? I thought that takes care of that problem.
Myth and legend.
Wait. I've been doing that since I've been 12 years old. Are you saying I'm just doing it for fun?
Were you so startled?
I guess. I was a very sheltered young man living at home.
Whoever has to repaint your room.
Oh, well, all those stiff socks are ugly.
Right. I don't even know what you're talking about.
So I got to ask you, because this is something men are always scared of. How did you know? Well, it's hard to ask you because you're a doctor.
Oh, it's easy.
But how did you know you were having problems?
Yes. What gives you a hint with prostate? Number one, you're going to notice stream change. The urine stream, you used to be able to knock a tile off the wall in a bathroom, slows down, gets trickly, thinner. Sometimes it's difficult to start. Sometimes it's difficult to finish. Sometimes you dribble after. That's one of the cardinal signs if you have a prostate problem. The second problem, when you begin to get up at night more frequently to use the men's room, that you have to urinate. The third is when you urinate and you think you're finished, and no more than 10 minutes later, you've got that urge again.
Gotta go.
Mm-hmm. those are all pretty non-subtle hints that your prostate may be growing.
I'm going to dig a bit more now that we talked about it, because when I'm also an insurance agency owner, and we sell a lot of insurance. And my question is,
if I was an insurance agent, I'm sorry to jump in, the number one thing I would also look at is family history.
Well, it's really none of my business. All we do is we ask them the questions, and it's up to the underwriters to do this. So that brings me to a question from when I first started in the industry. And no one's ever been able to give me a straight answer on this, okay?
I'll do my best.
So I was with a gentleman, and one of the questions you have to ask is, have you had cancer in the last 10 years? He said no.
Yes.
He said no.
Okay.
But he had his prostate removed.
Okay.
You can tell me whatever you want. It's really none of my business. But I mean, you don't have a prostate. So that being said, the next day he called me and said, you know what, I did a lot of thinking last night. It really bothered me that I said I didn't have cancer. And he said, I want you to change the application that I do have cancer, that I did have cancer. I should not, I do, if I did. So let me ask you this, and this has always bothered me. And like I said, I've talked to underwriters, I've talked to supervisors, I've talked to people in corporate at the different companies that I do work with.
Okay.
So my question is, 13 years ago, the guy had prostate cancer. They removed the prostate. He's cancer-free. This is 13 years out. And on the application at that time, you had to be cancer-free for 10 years. Why did they deny him?
Probably history of prostate cancer. That would be my best guess. Now, it sounds counterintuitive, but you can have your prostate removed. I did, but they can't always get all of it.
Oh, that's interesting. I was kind of wondering that.
It would be to take your whole prostate, absolutely, you would be damaging a lot of other things. You have to do some nerve-sparing surgeries, or else the gentleman will not be able to hold his urine, and he's never going to have an erection or an orgasm again.
Jesus.
It's one of those things where, to spare those things, there is going to be some residual prostate tissue.
See, I didn't know that. I did not know that at all.
Oh, yeah. That's one of those lovely wake up from anesthesia things where
Hey, guess what you can't do no more?
you can't hold your urine. That's always number one. Number two, are you going to be able to have marital relations of some sort? There are some ways around it. They have vacuum
I was going to
pumps
ask
in
you
the
that.
ring.
Yeah.
Pump in a ring sort of works, but it is.
But there's no ejaculate?
Yeah. Post prostate surgery, typically people do not ejaculate.
So I guess women that husbands come too fast, they're pretty
anything-
happy about this, huh?
Or if there's any ejaculate, it's retrograde.
I'm so sorry. I didn't mean to be inappropriate.
What'll
but
happen
it's
is
a question.
What'll happen is you either are not going to ejaculate, or if you do, it doesn't go forward out of the
Where the hell does it go?
penis. It goes back into the bladder.
Oh, so you're just going to piss it out?
Essentially.
Jesus. Well, that's awful. I hope I never get that.
Well,
Knock on wood.
there's a lot worse things that can happen
Yeah.
to you. In the big scheme of life, yes, it's not great to not be able to have, sex anymore in normal fashion, whatever your definition of normal is. But I'd rather be upright and breathing, not in
Oh,
pain, not
100%.
gonna die.
100%.
So you kind of take your good and your bad.
Now that we talked about men, I would like to talk about women too. And especially this kind of hits home for me because on both sides of my family, my ex's family and my family, there's been breast cancer.
Okay.
And having 3 daughters, they get checked all the time. I do know that. But I know you can't have a crystal ball, but statistically wise, are they going to have this problem down the road?
It's more probable if you've got a good, strong family history of breast cancer, and there's a couple familial breast cancer patterns where it's pretty certain you're going to get breast cancer during the course of your life. There are some family patterns where you're more likely to, and somewhere a little more likely. There, that all depends on which of the patterns you have. I'm not trying to be evasive.
Yeah.
but
Okay. Yeah. I have a bunch of questions. I'm going to go personal without saying who these people are. You know who you are when you listen, but I would never do that. I know someone that had breast cancer. He
Okay.
beat it, and it came back.
Yeah.
And she called me. She said, "Yeah, Eddie, I'm going to have a full mastectomy."
Hmm.
And I was like, "Is that automatic that you have the mastectomy when you have the first instance of it?"
No.
Explain that to me. Why?
Okay.
Because I couldn't
What
wrap
they
my
have
head
to
around
do
that.
is they have to look at the subtype. Not all breast cancers are the same. There's a whole bunch of different subtypes. Some are more aggressive, some are less aggressive. Some, when they find it, it's encapsulated, where it's one little tiny area, they can get that whole area and a clear margin out around it. They are going to try to spare breast tissue. It's a very big cosmetic, and it's a very big psychological issue with women. It is one of the more important identifiers. Like, I took care of a lot of people who had severe burns. I was in New York, and we had a lot of firemen and policemen in our practice where those things happened. The three big identifiers you have for you being you, things that people particularly have to preserve to have a good self-identity: face, hands, private area. And women are very, very sensitive about that. And you're going to want to spare tissue where you can statistically that it's safe. So some are going to have a lumpectomy. Some, they're going to look and say, with science and the numbers, that it's not safe to do lumpectomy. Your risk of recurrence is too high. They're going to have a mastectomy. That's how it's determined.
Now, my question is, and like I said, a lot of times when we have these conversations, I start to think of things as you're talking, and it's kind of like clicking in my head.
Go ahead, please.
So I have cancer in my one breast, not in the other.
Are you a woman or a man?
I'm a woman right now.
No, men get breast cancer too.
True, I know that. Should I get checked?
Unless you personally feel well, they would not want to do a prophylactic mammogram, sonogram on you. Barring there's one or two rare family syndromes where you are going to look at the men, but not quite as hard as the women.
So is it going to be in just one? Or if you have it in one, is it going to be in both? I guess this is something I never really thought about.
It's not engraved in stone. It's one of those things you have to lay the ball where it lies. Some people are going to have one breast only. They'll have a lumpectomy. Everything will be fine. Some will have both breasts. It is what it is, and you have to work around it.
Now, I know some women that have decided to get reconstruction, and others that have not. Is one better than the other?
It depends on, number one, what the patient wants, what they need to have to feel whole again. That's a primary determinant of whether you have reconstruction or not. If you don't want it, if you say, hey, I'm fine, I'll get a mastectomy bra and a prosthesis to put in it, okay, that's your choice. If you say, I don't feel as though I will be whole without reconstruction, they can attempt, depending where it was, how big it was, and what had to be done to remove the tumor. That determines how well the reconstruction comes out.
Now, a very good friend of mine, unfortunately, she got her results for her breast cancer, that she had breast cancer on her birthday. She was coming to my office to have lunch, and unfortunately, when I get nervous and I say really stupid shit.
Yeah, everybody will stick their foot in their mouth occasionally.
I asked her, I said, this is the perfect time for you to get stripper titties, and she didn't. What's up with that? You know who you are. You know who you are.
I will hold my tongue on that one. If I said something like that, I would probably end up in court.
Yeah, right. Eddie Buffalo can say it, though.
That's not fair. You can say.
I know. I can say whatever I want.
Well, most of the things you can say.
Most of it. because all the comments and statements by Andy Buckle and Dr. Andy are purely for entertainment purposes.
Well,
Now,
it's good to say that twice after a comment like that.
now, I have a friend that ended up having esophageal cancer.
Ooh, that is a very, very difficult cancer to
Yeah.
have, treat, survive, and pass from.
My question for you is that he thought it was kidney stones. What's up with that?
I have no idea how he could think esophageal cancer was kidney stones.
Was anything dripping down to his adrenal? I don't know. That's why I'm asking you
There's
this.
I can't think of a reason that esophageal cancer would cause kidney stones unless he had metastases to his kidneys and he had some sort of a renal failure where he made a kidney stone because of it. But that's a whole lot of reaching. I can't connect the two events.
I was just curious. Like I said, these are questions that go through my head,
Oh, sure.
you know, and it's people that I've known, you know. And,
Yes, no
you
dumb
know.
question.
So, another question is, pain-wise, what is the most painful cancer if you're going to end up getting it?
That's all. Pain is subjective.
Mhm.
People have different pain receptor distributions, different pain receptor sensitivities. However, cancers that are particularly difficult to relieve pain from, I would think off the top of my head, anything that involves bone metastases. I also have seen people with pancreatic carcinoma who really had a rough time. But there's a lot of subjectivity and different people, different pain. But bone metastases are notoriously painful. Pancreatic cancer is notoriously
I heard
painful.
that's painful. I heard bladder cancer is very painful too.
It's all subjective, and again, you have to, as a physician, listen to what the patient has to say, look at the situation, and work from there. You always have to play it where it lies.
So I'm gonna hit you with a bunch of different stuff. I'm gonna rapid fire you. Stuff you can live with and can't live without. Okay. Pancreatic cancer. Can I live without my pancreas?
The problem with pancreatic cancer is that it just doesn't stop with the pancreas. In theory, if it was just a pancreas, there would be ways to maintain your life.
Bladder
It would not be good, but yeah.
Bladder cancer.
You can live without your bladder, but again, if you have to lose the bladder, you're not just having cancer in the bladder. Typically, it's gone other places.
So what would they do in that case? Dialysis?
For bladder, no. Bladder, they would just make an exit where you'd have a urostomy, where there'd be a tube essentially from kidney to out of your abdomen.
That is very interesting. So I get lung cancer. Can I get a lung transplant, or is that or are you not well enough candidate for something like that?
Not all lung cancer is going to be fatal. Lung cancer,
it's changed, right, over the years?
Yes.
A lot.
Quarterly treated appropriately, you can have a sustainable life. It all depends what cell type you have, where it's located. I hate to make it sound like real estate, but location, and how early you catch it. And
that's a good question. So if you have, I don't know, are there cancer markers? Are there tests you can take if you have that kind of?
Let's talk lung cancer.
I'd like to know about that.
Okay,
yeah.
Now, if you meet the smoking requirements for it, approximately total of 20 pack years, and you've smoked within 15 years of, I think the time that they started, I want to say 50-ish. I'd have to look again. Sorry.
No, that's okay.
You get a low-dose chest CAT scan each year to look for it. So you catch it when it's 1. Yes, that's part of health maintenance. If you reach the criteria at the correct age and all, and shame on me for not having the age off the top of my head, you get a low-dose CAT scan annually until you're 15 years out from not smoking, or you would not be able to survive having a surgery to address what it finds.
Now, I have a question for Andy Freeman,
Yeah.
not Dr. Andy.
Sure.
You get some type of cancer, and knowing what you know, what would you not get treatment for? Yourself. And this is you, nobody else.
Personally, I would look at where am I going to be in 1 year, 5 years, 10 years? What do I expect? What am I willing to do? What kind of regimen or surgeries would I have to tolerate to get there? And I would individualize the decision. Most of the time, the cancer kind of makes the decision for you. I hate to say that.
Really?
Yeah. The three, but also, let's say you came into me and you were Eddie Packaday Buffalo, and you're 60 something, and you had small cell cancer of your lung. I would sit down and discuss 3 pathways. There's a super aggressive pathway with surgeries if they're going to be helpful, radiation if it's helpful, chemotherapy, genetic therapy. There is a comfort care pathway. People, when they think about comfort care hospice, they say, oh, that means we're giving up and we're not going to take care of me. No, it doesn't mean that. You break your leg, you're going to get your leg fixed. You have appendicitis, you'll get your appendix out. You get an infection, you get antibiotics. If it hurts, they treat your pain. If you're anxious, they work with your anxiety. What they don't do is they don't treat that cancer itself. And when the time comes that either your heart stops beating or your lungs stop breathing, you're allowed to pass naturally.
That's very interesting.
That's the second pathway. And the third pathway is kind of, I'll call it a la carte. People will treat some forms of the cancer's manifestations. You know, they may get some radiation if they've got some bone metastases. They may get X, Y, or Z, but they don't go full aggressive. The thing I always tell people with cancer, you are always in charge of your care. What you say makes or breaks whatever is going to happen. So people are always in charge. And second thing I tell people, they can change their mind. I've seen people who've opted to try very aggressive treatment, found that the way they felt, what the treatment entailed, and what they wanted were different things. And they said, I'm going to stop aggressive treatment. I want comfort care. They're in charge. They're allowed to. I've had people who just said, I don't want to do anything. I don't want to do anything. Comfort care, comfort care.
And that's up to them.
And then something has changed and they say, I want to accelerate the aggressiveness of my care. Yep, you bet. As long as you have decisional capacity, which is essentially you can make the same decision the same way twice, you are in charge of you. You are always the captain of your own boat. And the captain can change his or her mind. I try to empower people and tell them that. I'll also tell people sometimes they'll be given advice. They'll be told, hey, Ed, that cancer spot that we talked about, it's one little tiny guy. We can take it out surgically and your risk goes down to whatever the heck it is. And Ed says, no.
I don't want to do it.
Right. Does that mean the surgeon's going to be angry at him? Does that mean his primary caretaker or his oncologist or both are going to be angry and not want to take care of him? Heavens, no. The guy's allowed to say no. You're always allowed to say no. And we're here to take care of you no matter what your decisions are within reason. Somebody can't come to me and say, hey, I would like to have, syringes full of morphine and Dilaudid just in case and blah, blah,
You got any of
blah.
those with you?
No.
Wink.
But within reason, within medical reason, patient is in charge. Patient can change mind. Physicians are going to take care of the patient whether they agree or disagree with his current decisions. That way you're in charge. It gives people a lot of comfort knowing it and knowing that they've got that person to be at their side and walk with them every step of the way.
Some scary stuff.
It
really
is. That's why I'll sit down. I'll have people in, we'll go with Ed when he's abnormal CAT scan. We'll sit down. What I typically do is I draw a picture, I show you where it is, and I'll draw something that's the exact same size. That way you can visualize, okay, I've got a green pea. Okay, I've got an apricot.
Because some people, they don't want to know. I
You'd
can
be
see that.
surprised. That's very uncommon. And there, what I do is I offer alternatives. I say, if you don't want to know, do you want to have somebody else who you know and trust be aware of what's going on, so that when the time comes that you want to know more, do you want to hand that off?
What I want to ask, and like I said, a lot of these things come to my head when we're talking.
Sure.
I didn't think of it.
Absolutely.
But how do you take care of, like, mentally for these people that are, you just gave them this horrible story? Is there any kind of support system with like a psychiatrist or therapist or whatever?
Oh, absolutely. Number one, I make sure the person is empowered. They are in charge. Number two, I make sure that they know they can change their mind. Number three, I make sure that they know they have my unwavering support. I also make sure the person knows that there are medications and approaches for the anxiety entailed. There are medications and approaches for depression. There are medications and approaches for any pain or discomfort that's entailed. And I make them aware of what the resources are, and we work together and choose what they need at the time. You'll be surprised. People in general are a lot stronger and a lot wiser than common sense would say they are.
Well, we can't say the S word, so I'm going to put it this way. Do you ever have patients that take their own lives when they find out that they're terminal?
I've seen that happen, yes.
Be very careful. You cannot say that S word.
Oh, that I know.
Yes.
I've seen people make decisions that I do not agree with, and there I work with them. I'll try to usually screen for that when I'm dealing with bad news.
Mm-hmm.
I try to look for that person and see if there are any indicators, and there are some. It's an art, not a science, unfortunately. There are some indicators that people are not going to really do well with that, and I try to always have support from the get-go.
That's good.
I try when I have somebody in the
I never even thought of that kind of stuff until we started talking
it's
about
one of the
this
first
right
things
now.
I think about it. I say, how isolated does this person feel? How desperate do they feel? How hopeless do they feel? Who can I recruit with them? If I have news that is difficult, I try to encourage them to bring a second person that they trust. Because when I get bad news, difficult news, confusing news, I try to say, how much of what I say is going to really stick with that poor patient? And that's why I'll sit, I'll draw, I'll kind of hand together, we'll kind of make a little info sheet that they take with them afterwards, so that they know what we said and they can look back at it, have perspective, visualize it. And most of the time, if I can visualize something, if I can wrap my head around it and really see it, it takes a lot of the fear out.
Jeez. It's some very scary stuff.
Oh, it's really, really scary.
But that's what you wanted to talk about. Something scary.
Right. The good news is, if you work with a practitioner you trust and care about, who trusts and cares about you, if you keep communication open, if you get support when you need it, and it's okay to ask for help. Men are the worst.
I'm sure.
You're going to do all right.
Well, I hope this was helpful for some people. We're at the end of another show of Ask Dr. Andy, number 12. Very interesting. Let us know in the comments if you have any questions. Like we just scratched the surface on this thing. I'm sure we're gonna have to talk about it again. Because I wanted to talk about like treatment and why some people respond to certain things and others, because I know my father didn't have any adverse reaction to chemo, which I thought was crazy.
It all depends. The thing I would say, after having a very sad, serious talk like this, the take-home message is look, listen, communicate, and be aware that it's okay to ask for help. And there is always help. There is always an alternative. You know, that's part of our rights as people, you know, for help, you know.
And no, your buddy Andy Buffalo doesn't do coke. I think Dr. Andy's cats are getting me again. So my nose is starting to run, and I apologize for that. But we're going to end the show like we end every other show. If you like, if you enjoy life, if you have a passion for life, if you like working with people that are just like you, are the people you want to be working with, you can reach us at ebiagency.com. You can also reach me at Eddie Buffalo Insurance at eddiebuffaloinsurance@gmail.com, and our hotline is 716-541-4118. Just remember, everybody, things get tough. Life is definitely worth living. What do you got to do, Dr. Andy?
Just keep fighting.
Just keep on fighting, baby. We'll see everybody later. Thank you for spending your time with us. Take care.